My name is Singh. I'm an interventional cardiologist here at St. Joseph's Hospital and member of the valve team for St. Joseph's Hospital, Tampa, Florida. Unfortunately, we cannot treat aortic stenosis with medical therapy. It is a mechanical problem, and hence the only treatment for this condition is an aortic valve replacement. Aortic valve can be replaced either traditionally with a standard surgical aortic valve replacement, and or here at our Heart Institute, we can provide patients with a transcatheter aortic valve replacement. Transcatheter aortic valve replacement has been approved for two groups of patients. One, patients who do not qualify for surgical aortic valve replacement because they are too high a risk and or are inoperable. Two, for patients who are not inoperable but are high risk because of their comorbidities. In those patients, up until now, there was no treatment available for this very terminal disease process. And unfortunately, time and again, we would see the patients die without us being able to do much to help alleviate their symptoms. Thankfully, now we have this new technology which can be used to provide treatment to such patients if they have a reasonable quality of life left behind and are not terribly sick to undergo transcatheter therapies. Hence, it is very important once a patient is identified to have severe aortic valvular stenosis and are symptomatic from the disease, that these patients be referred to a valve center for further evaluation so we can provide them treatment in a timely manner before they become too sick to get any treatment at all. Medicare and CMS guidelines mandate that every patient who is being considered for a transcatheter aortic valve replacement is evaluated by every member of a valve team. A valve team is an integral part in the management of such patients. It includes an interventional cardiologist, cardiothoracic surgeons, imaging cardiologists, anesthesiologists, and other physicians and healthcare providers who help us take good care of such patients. It is a complex disease process. It involves input from a multitude of specialties, each of which brings their own unique skill sets to help provide the best care that we can to the patients so we have the best possible outcome, most expedient care, quickest road to recovery, greatest alleviation of symptoms, and perhaps an improvement in survival. I, as an interventional cardiologist, have a role to play in the pre-TAVR evaluation of such patients. Each patient that is sent to a Heart Institute for consideration for evaluation of TAVR has to undergo a thorough evaluation. This includes a thorough physical examination, imaging studies, gated and non-gated CT imaging studies, assessment of the cardiovascular risk, assessment of the surgical risk, and a cardiac catheterization, including assessment of the coronary anatomy. During the TAVR procedure, the interventional cardiologist and the cardiothoracic surgeon collaborate to perform the procedure. The recovery of a patient after TAVR is contingent on how healthy the patient was prior to the procedure. Patients who are much sicker before they undergo their transcatheter aortic valve replacement have a longer road to recovery. Patients who are functionally active, well preserved, and compensated from a heart failure standpoint have a much quicker road to recovery. At our institution, we have had patients who have been discharged within 48 to 72 hours of their transcatheter valve replacements. Hence, it's very important to refer the patients to us on time. Once they are sick, the road to recovery is much longer. There's a significant improvement in the quality of life for patients who have undergone transcatheter aortic valve replacement. Several of these patients may have New York Heart Association functional class 3 or 4 status, wherein they're not able to attend to their daily activities of living. However, once they have had a successful transcatheter valve replacement, they're able to return back to their normal lifestyle, and there's a marked improvement in their New York Heart Association functional class status. 80 to 85% of the patients who have undergone TAVR at our institution now have functional class 1 or functional class 2 status. St. Joseph's Heart Institute, we have a very successful cardiac rehab program. We recommend all our patients who have had a transcatheter aortic valve replacement to undergo cardiac rehab once they have been discharged from the hospital. It has been shown time and again, patients who have had cardiac rehabilitation following any major cardiac interventions, including a TAVR, have a much better quality of life once they have completed cardiac rehabilitation, and also in some studies they have been shown to have improved lifespan.